This is Catherine Poole, President and Founder of the Melanoma International Foundation. We are pleased today to present Stage 3 Decision-Making and Beyond by Dr. Jason Luke. This is one of the most challenging areas that melanoma patients face. Prior to coming to the University of Chicago, Dr. Luke was an instructor in medicine at Dana-Farber Cancer Institute and Harvard Medical School, where he treated patients with melanoma and performed early-phase clinical trials. Dr. Luke's research focuses on therapeutic advances for melanoma and early-phase drug development, particularly immunotherapy. I find it very impressive that Dr. Luke works to bring a personalized approach to each patient through a comprehensive, compassionate, and individualized care plan. That's what we're always looking for. Please stay tuned as we will ask your questions at the end of this presentation. So we welcome Dr. Jason Luke.
Thank you very much. It's my honor to be able to present the presentation today, which is entitled Decision Making for Melanoma, Stage 3 and Beyond. And before we get going, I'd like to just make a few comments. For full disclosure, you can see that I am an employee of the University of Chicago. I do have consultancies for scientific consultancies, Amgen and Array Pharmaceuticals. And I do perform clinical trials with basically all of the pharmaceutical sponsors who participate in research for new drugs for melanoma. Today, I'm going to be discussing several areas around the primary management of melanoma and thereafter. So specifically, firstly, around surgical approaches for melanoma. Secondly, what we refer to as adjuvant approaches, or approaches after surgery before melanoma could come back. And then thirdly, talk about new approaches in terms of deciding which patients might be at increased risk, and new ways to treat melanoma in terms of intralesional approaches directed specifically towards the tumor. So we'll cover all of that today. I'm going to move forward initially again by discussing surgical approaches for melanoma. And on this slide, what you can see is a summary of the various clinical trials that have been completed comparing the surgical margins for patients who have melanoma depending on the thickness of their tumors. And obviously this isn't up here for you to memorize, other than to highlight that there actually has been a lot of research around this area. And despite there being consensus, this is actually still an area that's open to research. So on the top-hand panels, you can see different clinical trials, the thickness of the tumors in the second column that the patients had who participated in these trials, and then what the comparison was in the third column. After summarizing all of these trials, a consensus has been reached by various different scientific and expert committees to suggest, as the bottom shows, that depending on the thickness of the melanoma, the margins taken around the tumor are of various sizes. And actually, it's not that hard to understand. So anything less than 1 is about 1 centimeter, 1 to 2 is about 1 to 2 centimeters, 2 to 4 millimeters turns into 2 centimeters, and again, more than 4 millimeters, still 2 centimeters. And that's a strong evidence-based approach at this point, and really should be something that all melanoma surgeons should be adhering to, with the only caveat being that if the melanoma presents in a location on the body which has anatomic difficulties, like say the face or the inguinal region and other places, sometimes the margins can't be quite as wide as would otherwise be recommended. From there, we will discuss some of the recent data. And so at the American Society of Clinical Oncology annual meeting this prior year, there were 2 abstracts specifically of importance around this idea of what kind of surgery should we do. And so the UK melanoma margin study was presented, and that's shown here. On the right-hand side, you can see a flow chart where you can see that patients were randomized who had greater than 2 millimeters of depth for their melanoma to either receive a 1 centimeter or a 3 centimeter margin. And we won't go into all the details around this, some of which are shown on the left-hand side, but suffice it to say that patients with at least 2 centimeters of depth either got a 1 or a 3 centimeter margin. And the important take-home point here is that there did not seem to be a substantial difference. And so these two graphs that are shown are called Kaplan-Meier survival plots. And on the left-hand side, it shows how long people survived after having surgery for melanoma. And statistically, it appeared that there was no major difference between 1 and 3 centimeters. And on the right-hand side, you can see the melanoma-specific survival. In other words, did those patients pass away from melanoma? Now, the authors suggested that this possibly was slightly significant in that the longer margin, the 3 centimeters, would be better than the 1 centimeter. However, there was criticism of this study that not all of the patients who participated in the trial got included in the final analysis. And so when these results came out, it was suggested by commentators that, in fact, this did not change our paradigm. And instead, the recommendation, again, is for less than 1 millimeter, a 1 millimeter margin, 1 to 2 being 1 to 2 centimeters, and then greater than 2 being 2 centimeters. Thereafter, a question becomes that the standard of care is to consider evaluation of the lymph node basin. And so commonly, patients who have a resection of melanoma that has high-risk features or is at least 0.75 millimeters will undergo a sentinel lymph node evaluation. And what that entails is, generally speaking, a dye is injected into the melanoma before it's removed, and then we search for the lymph node where that dye eventually moves to. Because the lymphatic system in your body is sort of like the garbage system, and it will naturally move particles from certain places in the body to other places, the lymph node being sort of the end garbage can. And those data are based upon some very important clinical trials which have been done over the last 20 years or so. The most important of those being the MSLT1 trial, which on this slide is shown on the upper left-hand side. And this study set out to evaluate the utility of evaluating that process I just referred to, sentinel lymph node biopsy. On the right-hand side, you can see the final analysis that was published in the New England Journal of Medicine in 2014, which suggested that performance of a sentinel lymph node biopsy clearly would improve our prognostic accuracy for as to whether or not the melanoma was likely to spread. And that's sort of immediately obvious, because if the melanoma is found in that lymph node, then clearly it has spread. But beyond that, it also has helped us to risk stratify patients to see how likely is it that the melanoma is going to spread even further. So based on these data, and on the right-hand side, you can see that on the bottom right-hand panel, it looks like the disease-specific survival for thick melanomas is improved by doing a sentinel lymph node biopsy. Many surgeons would advocated that this would improve the overall survival of patients, meaning if you had a melanoma, it would be more likely you would have long-term survival if you had this procedure. However, that is a point that's in contention, because if you look at some of these other plots, so A, B, and C on this slide, they look very similar. And so there are, for different outcomes, melanoma-specific survival for intermediate lymph node, intermediate melanomas, thick melanomas, and then disease-free survival for intermediate melanomas. The results are somewhat equivocal. So doctors disagree as to whether or not performance of the sentinel lymph node biopsy will actually cause people to live longer. That being said, there is broad agreement that performance of this kind of surgery does help us to better understand what the risk involvement of the melanoma is. If it hasn't spread to the lymph node, it's usually of less risk. So because of these questions that are still unanswered about whether or not the surgery really allows patients to live longer, another clinical trial called the MSLT2 trial, which is listed on the left-hand side on the bottom, is looking at another procedure to try to better understand. Because many people listening will likely know that if a lymph node is found to be positive on a sentinel lymph node biopsy, commonly a completion lymph node biopsy is then recommended. And a completion means that all the lymph nodes in the area around that lymph node that was positive get removed. So to date, it has not been proven that removal of all of those extra lymph nodes actually improves the survival of patients. But again, it's very clear that that tells us how risky the melanoma is. So some doctors agree and some doctors disagree about the utility of doing that surgery. That being said, broadly speaking, I think it is still considered standard practice that if a sentinel lymph node is found to be positive, that a completion lymph node will be completion lymph node dissection procedure will be performed thereafter. But moving forward, that question is also being investigated. And so again, from the ASCO annual meeting this year, there was a data presented from Germany evaluating the utility of doing that completion lymph node dissection, that second surgery on the lymph nodes. And this was from the German Dermatologic Oncology group, or the DCOG group, and this was the survival of patients with melanoma with positive sentinel lymph nodes if they did or did not undergo the lymph node dissection. And long story short, in this study, many patients were initially evaluated. This didn't show up exactly perfect, but about 4,600 patients were found, of them about 930 were found to be positive, and those were then randomized to either get the lymph node dissection or not, and about 279 patients in each group got the lymph node dissection. And the results were very interesting. As I suggested, there is some debate around this procedure and what the various survival curves, the distant metastasis-free survival, meaning did it spread somewhere else? The melanoma-specific survival, meaning how long did patients live after melanoma, live after surgery from melanoma? Recurrence-free, meaning where did it come back at all? And then a number of subgroup analysis. All of them showed that the two arms of the trial were very similar and not statistically different. And so that really raises the question that despite us knowing that these completion lymph node dissection procedures do tell us more about what the risk of the melanoma is, it's not really clear whether or not patients truly do better in terms of survival over the long term because of that surgery. In the past, there was advocacy that performing these surgeries was important because unfortunately we didn't have very good treatments for melanoma if it came back. Though, as many people in the audience will know, that's changed quite dramatically over the last 5 years, such that we do now have several effective therapies that can be administered, so the utility of doing the surgery is still somewhat unclear. And eventually getting the results from that MSLT2 trial, that very large clinical trial to evaluate the role of this surgery, will be quite important. So there were some questions that were residual from the presentation of this DCOG completion lymph node trial. One of them was if the nodal basin, meaning the area where the surgery was not an increased site of recurrence, then where did all of the patients have the melanoma come back? And that's commonly a question that I get asked patients. They say, well, if it comes back, where is it going to come back? And we really are unable to say, but perhaps by further analyzing some of these data might have some sense of that. Another question is, for all clinical trials moving forward, should we require the patients to have the completion lymph node dissection? We don't really know the answer to that. I think for the current time, the answer really needs to be yes, because otherwise we'll have a large degree of difference between individual patients that will make it hard to interpret the results. And then finally, how should the guidelines be written? Should patients always be recommended to have this surgery or not? And these are open questions that doctors are debating, which hopefully over the next year or so we'll have more answers to. So from there, we're going to move on to the risk of the melanoma. So we do these surgeries both to remove melanoma, obviously, but also to establish the risk overall. And what is shown on this slide is the AJCC staging system, the 7th edition. And so many people in the audience, again, will know that the way that we determine the stage or the risk of recurrence for melanoma is a combination of factors known as the T, or the tumor thickness, the N, or lymph node involvement, and then M, which is metastasis or spread of the tumor to other places. So what this slide shows is various graphs which show the survival rate for patients based on these different factors. And what has been highlighted here are those patients who are, generally speaking, deemed to be at high risk. So on the upper left-hand panel, that green line that you see are patients with T4B melanomas. And what that means is a very thick primary melanoma on the skin of more than 4 millimeters, as well as the presence of ulceration. On the bottom panel, you can see that as we get this actual staging system, that generally speaking, for patients who do not have lymph node involvement, those patients deemed to be at higher risk are usually stage 2B or stage 2C, because you can see that their risk at 5 years starts to approach somewhere on the order of about 30 to 50%, and that's about right here. The lymph node status also makes a big difference, and you can see that if you have one lymph node here in red, it's generally speaking, it's of higher risk, but not nearly as high a risk as if you have more than 3 lymph nodes here in green. And similarly, our survival rates after we see involvement of lymph nodes are very different depending on how many. If you have just one lymph node, survival is here in blue, as opposed to many here in green. And so these data are very helpful to us to be able to tell individual patients what the approximate risk of the melanoma coming back over time is, but additionally for thinking about whether or not patients should consider what we refer to as adjuvant therapy or systemic treatment with a drug to try to reduce the risk that melanoma could come back. And so the various different treatments that are currently available for patients, I apologize about this slide. We had a click was supposed to activate, but it's sort of here already. But you can see in the background that the standard of care approaches for high-risk patients include observation, meaning to watch the patient and evaluate for any recurrence of the tumor, interferon alpha, which is a cytokine therapy, biochemotherapy, which is a combination of interferon and chemotherapy and another treatment, and recently Ipilimumab, or anti-CTLA-4 monoclonal antibodies, also been approved by the FDA for the adjuvant therapy of melanoma. So all of these could be considered standard approaches, and the guideline statements clearly say that observation is the standard, and that beyond that, patients can be considered for other treatments. And so I think that that's very important for patients to understand. While each of these drug approaches has been associated with some kind of positive outcome for treatment after surgery, none of the data are so strong that all doctors agree that patients need to take these treatments. But many patients, especially those who might be at higher risk, do feel like it would be worth it to them to take these treatments. And in that context, I will promote that since we don't know the absolute best answer, participation by any patient where it's possible in a clinical trial would really be the preferred option, so that we could truly understand what's the best option for patients. But considering all of that, I'm going to go over each one of these as options so that people understand what they are. Before I move from this slide, I'll highlight again observation. So depending on the risk status, some of my patients, I see them intermittently, meaning every 3 to 6 months, with some form of re-imaging study, and that might be a PET scan or a CT scan. And how often and how frequently I see them is really dependent upon that staging criteria that we discussed before and the comfort level of the patient. It's a communication between the doctor and patient deciding what's best for making a decision together. But if patients are going to consider a treatment, the ones I highlighted here are the different options. Before I move to them individually, I'm going to show you a sort of a complicated slide showing those staging by all the TNM criteria, as well as the staging criteria on the left-hand side. And you'll remember that I talked about those patients being considered to be mostly at higher risk are stage 2B, 2C, and then those patients with lymph node involvement, which is stage 3. And what is shown on the right-hand side is where the clinical trial data that supports the use of these various drugs has been derived from. So it's important to note that all of the clinical trial data that underpins our recommendations has been generated in patients who at least have stage 2B melanoma. So for patients who don't have stage 2B melanoma, there's really no evidence-based recommendation for the use of any of these treatments that I'm going to talk about. And that may change over time, which we'll briefly discuss at the very end of the talk. But you can see here that many of the studies included patients, high-risk patients with stage 2B through stage 3C, and some of them included only patients with even higher risk of 3B and 3C, where the lymph node status really suggested a very high risk of recurrence of the melanoma. So what are the different treatments? Again, the first of them that I suggested was adjuvant interferon alpha. And so I put on the slide when I show this sort of how far we've come in the treatment of melanoma. On the upper left-hand side, you can see the cover of Time magazine from 1980, March 31st of 1980, stating that interferon alpha was the if drug for cancer, because when this drug was first found, it was thought to be a blockbuster, meaning that this might change the game and start curing a lot of patients with both melanoma as well as other cancers, actually. Unfortunately, that didn't really turn out to be the case. On the bottom panel here on the left, you can see that interferon is a very complicated molecule. Again, I don't show this because I expect everyone to understand it, but rather to show that interferon has many effects. Some of them regulate some of your immune cells like macrophages and NK cells, but interferons also have some direct effects on cancer cells, on melanoma cells, and kill them directly. So that was observed in the laboratory, and it was thought at the time, despite the fact we didn't understand it particularly well, what if we give it to patients? Maybe it'll keep the melanoma from coming back. And that's actually a highly contentious area. Many doctors disagree about what the value of giving interferon is. On this panel here, you can see many different clinical trials that are listed here in what's referred to as a meta-analysis, where the data from all these different clinical trials was presented together. And I won't go through all of these numbers. I'll go over here to this plot, this forest plot, which shows that if you plot out in these clinical trials the likelihood of whether or not you would get a favorable outcome for interferon, it looks in most of these trials like there is a little bit of a benefit, but really not very much, because you can see in aggregate it's just a little bit to the left of this one. And so I usually tell my patients that based upon the most recent data, there's approximately a 6 to 8% improvement in the survival of patients who get interferon. But the caveat to that is that interferon, unfortunately, has a lot of side effects. And so on this panel here, you can see what happens over time with interferon in many patients, and that initially there's an induction of fatigue and flu-like symptoms, which are really the first sort of symptoms that patients experience, again, with the severity being the worst really at the beginning with the flu-like symptoms, but improving. But over time, there's a host of other side effects, such as neutropenia, which is a decrease in your blood counts, neutropenia and anemia, liver toxicity, as well as depressive symptoms that develop over time. So interferon is controversial. Some doctors recommend it, some do not. The data that support it show a small benefit. And before we had other drugs, this was considered a standard option to go for because there really weren't alternatives. More recently, we do have some alternatives, which I'll discuss a little bit further now. One of them that's worth being aware of, although I don't necessarily advocate it, is a treatment with something called biochemotherapy. And this is a clinical trial which was published in the Journal of Clinical Oncology last year, performed by the SWOG Cooperative Oncology Group, where they randomized patients to either get a combination of chemotherapy drugs, cisplatin, vinblastine, dacarbazine, with interferon, as well as another molecule called IL-2, which is sometimes given for advanced melanoma, or compared with just interferon alone. And this is the schedule of what they did. Suffice it to say, as you could probably imagine, that this is a very hard treatment to take, because with all of this chemotherapy, patients tend to be very sick, they need to be hospitalized, so on and so forth. And the data that came out of this showed that the combination of all of these different drugs did show an improvement in terms of the time it takes for the melanoma to come back, the relapse-free survival. However, there was not a difference in the overall survival of patients. And so that makes this somewhat difficult to advocate for. So in this clinical trial, only patients who had positive lymph nodes were allowed to participate, and it showed it took longer for melanoma to come back. So that's a little bit like the interferon, only even more side effects. And so some patients do get a recommendation from their doctor to do this approach if the doctor believes there's a very, very high risk that the melanoma is going to come back and has a lot of very bad features. But I have to say, honestly, this approach is not used very much. From there, I'm going to transition to some newer immunotherapies and again highlight that we've made a lot of progress more recently in the treatment of patients with advanced melanoma, and that is trickling into the treatment of patients who are at high risk for recurrence of melanoma. And so this is the cover of Science magazine in 2013 describing cancer immunotherapy with T cells on the attack as the breakthrough of the year. And many people will know that Science magazine is possibly the premier medical journal that's out there. And the reason for all of this excitement was the development of a class of drugs called immune checkpoint blocking antibodies, the first of which being the drug Ipilimumab. And so whereas with these cytokines they had, like interferon, they had many effects that we didn't really truly understand very well, this is more like targeted immune system treatment. And in this panel on the left, what you can see is this is an antigen-presenting cell, or a cell in your body that would notice that there's particles or something going on, and it would activate this T cell, which is the first cell that actually does the work in the body. And that's through an interaction between these molecules here, the MHC and the T cell receptor, as well as the B7 and CD28. Well, what Ipilimumab does is it takes advantage of this process in terms of the off mechanism. Because when this process here turns this T cell on, the T cell actually immediately starts turning itself off. And that's through production of this molecule called CTLA4. And so Ipilimumab blocks the CTLA4, and that keeps this T cell from turning itself off. So Ipilimumab doesn't activate the immune cell, it actually keeps it from turning itself off, which is sort of actually an important sort of nuanced point about Ipilimumab and for understanding why some of the side effects develop. But the development of anti-CTLA4 antibodies with Ipilimumab was really just the beginning of this kind of approach. And again, many people who are listening will know that now we also have anti-PD-1 antibodies and PD-L1 antibodies, but beyond that, we're starting to develop antibodies against a number of other important immune molecules, ICOS, KIR, OX40, CD27, et cetera, because this is the new wave of cancer treatments, trying to harness the immune system to fight cancer. So Ipilimumab was developed for patients with advanced cancer at first and showed a substantial benefit in terms of keeping patients alive longer than they would otherwise have been. Ipilimumab has been evaluated in a clinical trial of patients who had surgery to see if it would keep the melanoma from coming back, and that's this clinical trial, which was called the EORTC 18071 trial. And EORTC is the European Cancer Organization. In this clinical trial, patients who had high risk of melanoma coming back either received Ipilimumab or received a placebo. And these are the curves, again, the survival curves showing in blue for Ipilimumab as compared to red with placebo. And what we find is that the hazard ratio for relapse-free survival, meaning what's the significance of whether or not the melanoma comes back, was 0.75. And how that translates into the way we usually talk is that means there was about a 25% improvement in whether or not patients had the melanoma come back when this data was analyzed. So about a 25% recurrence-free survival. And so that's important to understand. That's clearly a substantial benefit to Ipilimumab, but it has to be considered in the context of what else we know about Ipilimumab. So based on these data, Ipilimumab has been approved by the FDA for the treatment of patients who are at high risk for recurrence of melanoma, and some people have started giving this basically to all patients who are at high risk. Now that being said, we actually know a lot about Ipilimumab already. And so this plot shows the outcomes of patients with advanced cancer where it came back and couldn't be removed, about 5,000 patients who were treated with Ipilimumab. And what we see is that actually, unfortunately, it doesn't help most patients, but there's about 22% of patients who out here at about 3 years seem to be in a situation where the melanoma did not continue to grow. And actually, those people seem to do very well over a long period of time. And we call this the tail on the curve. So it's very clear that about 21 to 22% of patients have 3-year disease-free survival, and we think actually those people have long-term survival thereafter. So how does that influence what we think about Ipilimumab in terms of a treatment after surgery? Well, if we put those two graphs near each other, all of a sudden it starts to be sort of a nuanced question. On the left-hand side, you see the data from the clinical trial of giving Ipilimumab after surgery, where there was a 25% improvement between the blue and the red line. At the same time, we know that if we wait for the melanoma to come back and then give Ipilimumab, about 22% of patients seem to have long-term survival from that. So it's an interesting biological question. Is there a real difference of giving Ipilimumab right after surgery or waiting until the melanoma might come back? Because from my perspective, 22 and 25 sound pretty similar. Now, it's very important to note that there is no statistical comparison between these two things, and this is just a numbers observation. So it will be very important to eventually get the outcomes data from the clinical trial here on the left-hand side of Ipilimumab after surgery to see whether or not it truly improved the overall survival of patients. But at the current time, we really don't know. There's further nuance to it as well, however, because in this clinical trial in the adjuvant setting, Ipilimumab was given as a dose of 10 milligrams per kilogram. And that's actually different than the dose of ipilimumab that's approved to give to patients who have had melanoma come back, where we give 3 milligrams per kilogram. And that sort of makes you scratch your head. Well, why would it be that way? Well, it turns out it's a complicated issue about the way the drugs are approved by the FDA and the different clinical trials that are done. When ipilimumab was coming forward for the treatment of patients who had advanced cancer, there was a little bit of a rush to get it available because at that time there were very few treatments available for melanoma. And when the drug was approved, the FDA thought there wasn't enough safety data for the 10 milligram per kilogram dose and would only approve the 3 milligram per kilogram dose, and that became the standard dosing regimen that you see on the right-hand side over here. However, the drug company that developed ipilimumab was expecting that the FDA would say that it was okay to give 10 milligrams per kilogram, and they started this clinical trial on the left-hand side, which eventually showed these results. And so the dose that's approved for the adjuvant therapy is actually 10 milligrams per kilogram. Again, sort of a head-scratcher. So we're in an odd position of comparing a higher dose of ipilimumab after surgery than ipilimumab later. And we don't really know for sure whether or not that dose makes a difference, but we have suggested that perhaps it might make a difference in terms of the side effects that patients have. So what are the side effects of trying these immune system-like approaches? And they're actually very, very different than chemotherapy. In fact, they're sort of the opposite. But whereas with chemotherapy, the chemotherapy literally acts like a poison and tries to kill more tumor cells than normal cells, ipilimumab, or these immune system drugs, they don't actually kill tumor cells at all, and they don't really cause much in the way of side effects. They try to get your own body's immune cells to fight the cancer, but as a corollary, if your immune cells get all activated and messed up, they can attack your own body and cause autoimmune-like phenomena. And those present like a rash or pruritus, liver toxicities, diarrhea, or colitis is the one we worry about a lot, or hypophysitis, meaning mess up your hormones. And this is a famous now sort of figure which shows when we expect to see these different side effects after we give ipilimumab. And it's been very well described that the most common times to see these is you usually see the rash first, then sometimes we can see the diarrhea or colitis, and then the other things happen a little bit later. So those are conceptually what can happen. What about in these clinical trials, what happens? Well, this is the data from the clinical trial after surgery of ipilimumab. And again, these are referred to as immune-related adverse events because ipilimumab doesn't cause too many side effects otherwise. And what we see is that about 52% of patients had high-grade, grade 3 or 4, immune-related adverse events. And these are the kind of adverse events we usually think of as severe, meaning you might get hospitalized for this, or you definitely at least need a very aggressive intervention, usually with steroids or some other approach. So unfortunately, 42% seems like a pretty high number because some of these things are fairly substantial. The colitis here was about almost 8%, and those patients usually get hospitalized. There were a fair number of liver problems here, and some of the hormone things that got messed up as well. If you compare that to what we saw in the clinical trial of patients with advanced cancer, it actually stacks up very similarly. So again, we can't compare these exactly because they're from different clinical trials, but you can see that they're sort of the same kinds of side effects, and they're happening at frequencies that, again, are sort of high, relatively speaking, the 40 to 60% range. And so it's not a small thing to think about what are the ramifications of giving a drug. And so when I talk to patients after they've had surgery, we talk about whether or not to give ipilimumab, but we have to be careful because I like to think about things in terms of how likely is it the melanoma is not going to come back, meaning no matter what we do, there's not going to be any more melanoma. So if we give a drug like ipilimumab, the only thing we can do is reduce the possibility of it coming back. And in that situation, we have to consider whether or not the potential for these side effects, which can be severe, is really worth it. And so different doctors have different opinions and different recommendations, but I would say it's certainly not a slam dunk to think that just every patient who has surgery needs to get ipilimumab thereafter. So we go back again to our list of the available treatment options for patients in the adjuvant space, meaning after surgery, who are at high risk of the melanoma coming back. We talked about observation and interferon, biochemotherapy, and ipilimumab. But what about that clinical trial that I mentioned? Because, again, we don't know which of these treatments is the best treatment to give. And actually, as, again, many people probably know, there are a number of other treatments that have been developed for melanoma recently as well. And so this is a slide to sort of give you a sense of where we're at with the treatment of patients where we can't remove the melanoma. We call those unresectable or usually advanced patients. And before 2011, the only treatments that were available were chemotherapy and a treatment called interleukin-2, which is another kind of immune system treatment, but only some patients were able to get that because, again, it had a lot of side effects. And we knew that, unfortunately, before 2011, the survival of patients who had advanced melanoma, unfortunately, was not as good as we would have hoped. We commonly quoted it as meaning that the average patient who developed melanoma that spread would be about 9 to 12 months. That has radically changed, however, so much so that in 2015, we're really no longer able to actually predict for patients what the survival is if the melanoma comes back. And that's because whereas we only had like 2 treatments here in 2011, we now have this just explosion of treatments for melanoma. And we split them into a couple of different categories. One of them is targeted therapies, where we try to figure out what the gene is that's messed up in the melanoma, and can we develop a drug combination for that. And genes of interest in melanoma are BRAF, KIT, and then some others that are currently being investigated that are listed here. There are newer immunotherapies. I talked a lot already about Ipilimumab, but now we're also going to talk about these anti-PD-1 antibodies with pembrolizumab and nivolumab, as well as combining these. And then finally, the most recent approval is of a new kind of cancer treatment trying to use a virus to kill the tumor cells. And so this is a therapy called TVEC, which is a modified oncolytic herpes virus, where we literally infect the tumor cell with this virus, and it only kills the cancer cell, not infecting the rest of the body. So we're going to talk about all of these and how they relate to treatment after surgery now. So here's a summary of the major ongoing adjuvant clinical trials for melanoma. So one trial that's been performed, although we don't have all the data yet, is a trial called the E1609 study. And that trial compared Ipilimumab at both 10 and 3 milligrams per kilogram as compared with interferon to try to see, is Ipilimumab better than interferon to make the melanoma not come back. In the targeted therapy space for patients who have BRAF mutations, there's a trial called the BRIM-7 trial ongoing, where patients are getting the drug called vemurafenib or getting placebo to see if that can keep the melanoma from coming back. There's a trial called the COMBI-AD trial, again for patients with BRAF mutations, where they get the combination of dabrafenib and trametinib, which are BRAF and MEK inhibitors respectively, or placebo to see if that can keep the melanoma from coming back. There's a CA209-238 study of Ipilimumab as compared with nivolumab, again anti-PD-1 antibody we're going to talk about in a second, to compare them as adjuvant therapy. There's the SWOG S1404 study, which just recently opened, which is comparing pembrolizumab, anti-PD-1 versus interferon, similar to this trial we described up here. And then finally, there's a trial in Europe, the EURTC 1325 or Keynote 54 study, comparing pembrolizumab to placebo. So again, there's a lot going on to try to figure out whether or not any of these drugs can help the most or the best for patients after they have surgery, and we really don't know the answer, and we're not really going to know the answer for a few years. But this is why it's so important that patients consider participating in these clinical trials to help us understand what the best treatment to give is. But we're going to go forward now and explain what are some of these treatments for those patients who maybe don't know as much about them so far. So I mentioned the names of some of these drugs already: dabrafenib, trametinib, vemurafenib, and cobimetinib. These are drugs that block the protein called BRAF or MEK, respectively. So we know in about half of patients who have melanoma, one of the main reasons the melanoma grows really fast is because of a mutation in a gene called BRAF. And that's shown down here, where we see that in a normal cell, you have this cascade of events between what's called a receptor tyrosine kinase through the protein called RAS to RAF to MEK to ERK. And if all that happens, it makes your cells grow. Now, in melanoma cells, again, about half of them, there's a mutation in this gene called BRAF, which causes the cell to no longer respond normally to the rest of the body. and this tells the melanoma cell to grow all the time. And so once that was understood, drug companies were able to go forward and try to develop drugs that would block this abnormal protein called BRAF, V600. And subsequently learned as well that adding another drug that blocks down here at the level of MEK could even amplify this even further. And so when we understand that, we can go forward to the clinical data from patients with advanced cancer. And on the top, you can see results from a clinical trial where the combination of a BRAF and MEK inhibitor were given to patients who had BRAF mutant melanoma. And what this is something we call a waterfall plot. Each one of these lines is an individual patient and how much their tumor shrank. So what you can see is that with this treatment, almost all the patients have some degree of shrinkage of the tumor, with a substantial portion over here having the tumor completely go away. There are rare patients where this doesn't work, but those are really actually very rare. Now the caveat is this doesn't work perfect for everybody, but sometimes it can work quite dramatically. And here's down the bottom one example of an individual patient who had a lot of tumor spots, and they're shown up in the red. After starting the treatment for a month, we see that almost all of them have gone away. By 2 months, they're nearly all gone. But what we've learned is that in almost all patients, it seems like even though almost all these go away, there's still some cells left over, and someday most of these patients eventually have the melanoma come back. But as a consideration of a treatment after surgery, maybe there's only just a few cells left, and this approach can get rid of them. And that's the rationale for those clinical trials. What about the PD-1, PD-L1? And so this is a very complicated science slide. You don't have to try to understand all of it, but I'm going to explain it to you real quickly. Here we see a CD8 T cell. And those are the T cells that we think do the important jobs in the immune system, meaning to kill cancer cells. And what we can see here is that this immune cell has actually come in and gotten close to the tumor. So much so that it started to do the things that an immune cell is supposed to do if it's going to try to kill cancer cells and secrete molecules, specifically this one called the gamma interferon. And we now know that at least half of patients with melanoma, and probably more, the melanoma cell itself has a receptor on it called the interferon gamma receptor, which can notice this process. And in response, it will turn on this molecule called programmed death ligand 1, or PD-L1. And that PD-L1 can interact with this immune cell and actually turn the immune cell off. And so I explain this to patients. It's sort of like a cloaking mechanism or a hiding mechanism that the tumor cell is able to turn on to keep the immune cells from trying to kill them. And we've learned that this is a really, really, really important molecule in almost all cancers, actually, to keep the cell alive and not get killed by the immune cell. This is a picture showing actual individual cancer cells and what this looks like. The brown is actually the PD-L1 on the edge of the cell, shown here. And what happens is an immune cell will come along, and it'll touch here, and then the immune cell will go to sleep. And if the immune cell sleeps too long, it undergoes a process called apoptosis, otherwise known as programmed death. And that's where the name actually comes from. So understanding that gives you a rationale for why we would be interested then in developing drugs that block this. You can see that here on this slide. So here's some tumor cells, and they're showing the PD-L1, and here are the T cells that are supposed to kill the tumor, but they're blocked by the PD-L1. So if we could develop a drug that could unblock this and allow these T cells to kill the cancer, that might be highly effective. And of course, many people in the audience, again, already know that that is the case. And 2 drugs have been developed and approved for melanoma. They have the names pembrolizumab and nivolumab. And in patients who have advanced melanoma that can be removed, we find that these drugs can be quite effective. So this, again, this is one of these waterfall plots that shows individual patients and their response to the treatment, which in this case was pembrolizumab. And we can see that a lot of the patients have very significant shrinkage of their cancers, with some having complete shrinkage of the cancer. And it doesn't seem to make a big difference whether or not they had prior treatment with other immune system treatments like Ipilimumab. Perhaps the most important part about this is that whereas Ipilimumab, I said, had that high risk of side effects in the 40% range, here we see much less in the way of side effects, on the order of 10 to 15%. And so these drugs tend to be very well tolerated and very effective. So again, an obvious question then becomes, well, what about giving these drugs after surgery? And I already showed that many clinical trials are ongoing now to try to determine that. There are some people who argue that perhaps this won't really work in the adjuvant setting, because if you go back to our science back up here, if you don't really have all these tumor cells available, like a patient who has cancer that can't be removed, maybe there's no PD-L1. We don't really know the answer to that. It's possible if there's only 1 or 2 cells that giving anti-PD-1 antibody won't actually really work. But we don't know, and unfortunately our sophistication in understanding this really isn't as great as we sometimes make it out to be, and the only way we're really going to know is to perform the clinical trials that I talked about. There has been some experience trying to give these anti-PD-1 antibodies after surgery. So this was data from the Moffitt Cancer Center showing patients here in the bracket here who had actual metastasis or spread of the cancer. So M1A means it spread to the skin, B means to the lung, C means everywhere else. And you can see here that most of these patients had spread of the cancer. And on the right-hand side, what we can see is the follow-up for the patients over time. And the red arrows, what I showed was that at 2 years, about 80% of the patients were both relapse-free, meaning the cancer hadn't come back, and were still alive. And I probably don't need to tell people in the audience that we wouldn't really expect that 80% of patients who had had melanoma already spread once would still have had it not come back after 2 years. So this gives us a suggestion that perhaps this is something that's going to be effective, but in this clinical trial, there was no comparator arm. So this was a single-arm trial, so this hasn't been formally evaluated, which is why we're doing those other clinical trials now. But again, it's important to highlight that only about 15% of patients had significant or serious side effects from this sort of approach. So anti-PD-1 antibodies are exciting. They're a standard of care for patients who have advanced melanoma, and the clinical trials are ongoing to try to figure out whether or not they should be considered as a standard treatment for consideration after surgery. At the current time, they are not, however. So what about future directions for treatment for the adjuvant therapy after surgery or local treatment of melanoma? And so 2 questions arise. Can we figure out who the high-risk patients are who we are currently calling low risk? And secondarily, what about considering treatments that are actually what we refer to as intra-tumoral, or meaning actually injected into the cancer, as approaches to treat melanoma, perhaps before or after surgery, or even other kinds of cancers? And I'm going to talk quickly about TVEC, as well as some other kinds of treatments. Back to this complicated slide that I showed before that has the T stage, the N stage, the M stage, as well as the overall AJCC staging. Before I mentioned that the high-risk patients were those considered to have stage 2B, or definitely those who had stage 3, kind of down here. And so the question then becomes, though, so that if we're saying that, then we're saying that these patients up here are low risk. And is that really the case? And I guess that really depends on your perspective, because on the right-hand column here, you can see the 5-year and 10-year survival from before we had effective treatments for melanoma. And what you can see is that, yeah, if you have stage 1A melanoma, meaning a very small tumor that was removed probably by your dermatologist, the chances of survival are very, very high, 95%. But as soon as you start to get melanoma that was a little more invasive into the skin but didn't touch any lymph nodes, all of a sudden the 5-year survival goes down. Now it's 77. If it was a little more deep, all of a sudden it's 63. So certainly there are some patients in here who really are not low risk but are actually high risk. And so the question becomes, can we figure out who those patients really are who are going to have the melanoma come back? And there's a lot of work being done to try to sort this out. We can learn from some of our colleagues in other diseases as to how this might be done. And this slide I show is actually from breast cancer, describing a treatment that's FDA approved called the Oncotype DX score. And what it is an evaluation of which genes are turned on or turned off in the cancer. So in the context of breast cancer, you can see this graph here on the left-hand side. All this green stuff means that the genes are turned on. All this red stuff means that the genes are turned off. And what we can learn is that if we take all this into account, we can make a plot to suggest whether or not we think the patient has a good gene signature or a poor gene signature. and then track the outcomes of the patients. And what we see is sort of obvious. The patients with the good gene signature, they don't have the breast cancer come back, whereas those with the poor signature, those do have the melanoma come back. The breast cancer come back. So that's really important, however, because for breast cancer, the way they use this then is that for these patients, they do not give them chemotherapy. But for these patients, they do give them chemotherapy. And in melanoma, now that we have drugs that are more effective and have less side effects, perhaps we could think in the future about doing something like that. So are we moving towards that kind of a world? And I would say that we're sort of moving there, and I think in the future this will become an important sort of test. And the reason that I say that is that there have been some tests already shown in research studies to be able to putatively do this. So this is a test which, again, is looking at the gene expression profile and looking at whether or not the melanoma recurred and spread and how long patients lived thereafter. And these were in patients with stage 1 and stage 2 melanoma. And what you can see is if you had the good gene score, almost nobody had the melanoma come back and spread, and everybody survived. Whereas those patients that had the poor gene score or the bad gene score, that's where we saw the melanoma might come back, so on and so forth here. And so that's sort of obvious. And the question is, are these tests ready for prime time? And I think there's a difference of opinion in the field about this. All of the data I show here are retrospective, meaning that we've looked in patients' charts and we've followed this, but we haven't done this prospectively, meaning taken patients who have surgery, do this test, and then see if it can really predict real well. And so experiments like that need to be done, and some of them are being planned currently. But again, I'll just point out that as a preliminary analysis, if we looked at the utility of defining this gene expression profile, class 2 meaning bad, and compare that to the surgeries that we do sometimes, in this very small data set, which has the potential to be biased and confounded, it looks like it's possible that the gene expression score might be just as good as the surgery. Now, I do not want to advance the idea that patients should not be having surgery for melanoma. It's absolutely the case that the standard approach is surgery. We've treated 20,000, 30,000 patients with melanoma, and we know surgery is effective, and it can tell us what the risk is. What I'm saying with this is that in the future, it may be possible to augment the surgery with some of these other tests to help us better define who the patients are that are at high risk. This is data that goes to that point. What we see here are survival curves of different patients who either had the class 1, which is the low risk, and either did have a sentinel lymph node that was positive or negative, or class 2, meaning high risk and either had a sentinel lymph node biopsy that was positive or negative. And what we show at the bottom is that in this group of patients, again, it looked like if you had the class 2, your risk of the melanoma coming back was basically the same whether or not you had had the surgery or not. And I, again, take this to mean that this is really interesting, and we really need to understand this better, because this may eventually help us to understand which patients might need the surgery and which patients might not need the surgery. From there, I'm going to transition to the treatment of actual tumors that are on the skin or can be reached like a lymph node with a needle. And here, I'm highlighting the National Comprehensive Cancer Network guidelines for the treatment of stage 3 unresectable or stage 4 skin-based melanoma. The reason I'm doing this is there's been a lot of interest lately in the media, as well as an actually approved drug for melanoma for this intralesional approach. And so I highlight this to note that at the current time, the only indication for giving this sort of a treatment is if melanoma has come back and can't be removed on the skin or in an in-transit recurrence or a lymph node. And in that situation, this guideline panel, the NCCN, suggests that consideration of an intralesional therapy is a reasonable option. And so this is an area which I think has a lot of potential for new drugs, which possibly someday could be important in consideration prior to or after surgery. So I think it's important that people be aware of them. And so the first of these to be developed was this molecule called TVEC. And so I alluded to it before. It's a modified oncolytic virus. So this is literally the case that a patient has a lesion on their skin, and you take a needle and you stick the needle in the melanoma and you inject in this virus. And I always butcher the name here, so I'm going to continue to call it TVEC, but I welcome all of you at home to try to pronounce this in your free time. So what happens is that this virus infects the melanoma cells, and over time will cause the melanoma cells to burst, just like viruses do all the rest of their body. Now the difference is that the important genes in the virus that would normally allow it to spread all over the body have been removed in the laboratory. And instead of having those genes, we've inserted a human gene called GM-CSF. And that gene is important for activating an immune response. So after the virus blows up these cells, it releases these immune particles. Those immune particles then recruit in the dendritic cells that I actually mentioned earlier, which then help to activate the T cells, which do the tumor fighting function. And this then causes more immune activation and killing of tumor cells. And that's the rationale. So when you inject this virus, you both blow up this cell, but then you spread this immune effect into the area. And it's worth noting that these injectable approaches, this is approved only for skin melanomas or melanomas that can be reached with a needle. But in the future, it may be the case that we do this injection of the tumors in combination with some of the other treatments that I talked about, like BRAF inhibitors or immunotherapy like anti-PD-1. These are the data for TVEC, showing that those patients who had melanoma, again, on the skin that had come back, did substantially better in the blue line as compared to getting the GM-CSF molecule, that's the immune molecule that was in the virus, alone. And again, this was good enough that the FDA approved this therapy, and this is something that many doctors who treat melanoma are already giving as a standard approach, again, for melanoma that's come back. But this is just the first in class of these intratumoral therapies. There are a whole host of them of different mechanisms that are being developed. So there's a molecule called rose-bengal or PV10, and this is actually a molecule, it's a stain that pathologists use under the microscope, but it was realized that this can actually kill tumor cells, and so now is being used to inject tumor cells. There's another virus, the Coxsackie A21 virus, which is being evaluated in a very similar idea to TVEC. There are other immune molecules that trigger the immune cascade of events. One of them are toll-like receptors, and so agonistic molecules are being developed to go after those. Another really important immune molecule is something called STING, and that molecule actually is the molecule in your cells that helps your cells to notice that there are tumor cells around, and a molecule against that is being developed. There are approaches, again, referred to as electroporation, where they give a small electrical field, which allows some of these molecules like chemotherapy or interleukin-2 to actually go across the skin or to go across the tumor's cell membrane and to get into the tumor, and this can actually kill the tumor cells as well. So again, many approaches are being developed in this idea, and this is where, again, I would strongly recommend that really in any case where you're at in your treatment that somebody consider participation in a clinical trial, because we have all of these great ideas. We really don't know yet which one is best. And beyond each one individually, there are multiple combinations of all of these things being looked at. So not only which drug itself is best, but which one is the best to give together with another drug or give after another drug. And clinical trials evaluating all of that are ongoing. So with that, I'm going to say thank you very much, and I'm going to conclude with a few comments. One, I'm going to say again, we're going back to the surgical margins. They're not too tough to remember. If your melanoma is less than 1 millimeter, then your surgical margin should be about 1 centimeter. If your melanoma is more than 2 millimeters, surgical margin should be about 2 centimeters or more. For lymph node evaluation, sentinel lymph node evaluation is still a standard approach, meaning we should check and see if you have a large melanoma or a deep melanoma, whether or not it's spread to the sentinel lymph node. Completion lymph node dissections are also considered standard by many people, but their value is under debate. And doctors disagree at this point about how important it is to do those surgeries. And so discussing the evidence as to why it's a good idea to do that is probably an appropriate thing to do with your doctor. Adjuvant therapy for treatment after surgery, again, observation is the standard of care. But beyond that, there are other treatments now available, like interferon, which has been available for a while. Ipilimumab, or Ipi for short, has also now been approved, again with caveats that I talked about. But possibly most importantly, what about a clinical trial to help us really, truly understand what the best treatment is moving forward? And finally, for the future, I think that we're definitely going to be able to develop tests, and possibly those around gene expression profiling, that can help us to better be able to predict which patients individually are likely to be at higher risk for the melanoma to come back. And finally, this new class of treatments that go directly after the melanoma cells on the skin or in the lymph nodes, these intralesional therapies, are really, really interesting, and I think more and more will become part of our armamentarium in treating melanoma, both after it's come back and probably in the surgical space as well. So with that, I'm going to say thank you very much. Again, you can see my pretty mug picture here on the left. You can follow me on Twitter, where I have perhaps the most boring Twitter feed ever, where I talk about melanoma and immunotherapy approaches. I work at the University of Chicago, and I always leave people with this sort of goofy cartoon about immunotherapy, where the cancer's grown here and the immune system's gotten all confused. He's a friend, right? But then after you introduce immunotherapy, the immune system can wake up and notice the cancer and attack him and hopefully kill the cancer. With that, we'll take your questions, and I'd like to say thank you so much for taking your time to listen to the program.
Thank you so much. Very, very thorough presentation, I must say. I learned a lot from it. We have some questions from our constituents for you. And I just want to start with my own comment that I agree it's kind of a head scratcher, this 10 milligrams versus 3 milligrams for Ipi. And I know I have a lot of doctors and patients, refusing to have this as adjuvant treatment at the 10 milligrams. So a lot of the doctors are saying to the patients, this might kill you. It's just such a high dosage, and then they're working it out in some realms where they're able to get the 3 instead. So yes, that was very confusing for
the comment I would make about that is that changing the dose sort of gets us away from what we understand about the treatment. The data that we have says that there's a benefit to giving 10. We don't really have any data that says there's a benefit to giving 3. Now, many of us think that's probably the case, but it's just worth cautioning about that changing the dose means we're sort of getting away from what we truly understand from the clinical trial data. I wouldn't advocate necessarily either way, but I would just point that out. It's possible that the benefit wouldn't be 25% if the dose wasn't 10. But I think further clinical trials will be required to sort that out. Like I mentioned, the ECOG 1609 clinical trial will actually compare 3 and 10 and should give us an answer to that. In advanced cancer, there is a clinical trial that compared 3 and 10, although the results haven't been described yet. It is the case that 10 causes some more side effects, although I don't think it's probably worth saying that it's so much so that it's like now 3 times more dangerous. There is an increase, but it's not a dramatic increase in the amount of side effects.
Well, I think our patients are pretty savvy in figuring out benefit versus, quality of life issues as well. So I think, that's going to enter into it. So, the benefit being, 10% or maybe 20%. But, the benefits, as we know, the reason we've had such issues finding a stage 3 adjuvant therapy is because frequently the patient doesn't have really any evidence of disease to measure it, as well as when you're in stage 4. So that's a problem. But my biggest problem with the trials are that, they're going up against placebos. And I think it's going to be very clear to patient and staff, who's getting a placebo and who's getting the drug. So I'm not sure that method works well with disease other than psychological disease.
Well, I guess so. I think that the introduction of a placebo often triggers alarm bells for patients. I can tell you that in my practice, my current standard practice for most patients is observation, and so it's placebo. So including, maybe they should call it something different, but including placebo or observation is still the standard of care. And so that's where it goes to individual decision making. But I don't think people should be scared of the placebo in and of itself. It's really, if you feel like that's not enough, then yeah, I would agree that you shouldn't participate in the clinical trial. But since, in my practice, I generally speaking recommend observation still, and I'm hopefully that will change over the next couple of years, but that's still what I recommend.
Okay, so you're saying that if a patient entered one of these trials, they would not be getting like an infusion of saline solution or something like that?
No, they would, but that's not really different than if we had just observed, I think.
Okay. Well, I think, we've had problems with clinical trial, design, which we could, do a whole nother webinar on, in the past where, we have them up against things like, interferon, which you're really going to know when someone's got interferon or they've gotten one of these other agents because of the side effects. And since, interferon does not prolong overall survival, that's an issue that many patients will express to me that they will drop out if they get the interferon. So
I think that's a very reasonable point about interferon for sure.
Yeah, it's like using dacarbazine as a comparator. It's very troublesome for patients to be getting something that they know doesn't really work and is toxic. So they are better off just with observation. And we always call it, observation as, when a patient chooses at stage 3 to just watch and wait, that we consider that still an aggressive therapy because they're going to be going, to their physician frequently, and they're going to be, very in tune with their body, any changes, and point that out right away so that if there is any, tumor growth, they'll catch it real early. So we don't like to downplay that as, not being aggressive, which, some people think that, watch and wait is being passive. But I personally think it's also aggressive if you pay attention and, follow up with your doc. So what do you think, I think we've answered a lot of these questions, like you said, that we have. Oh, if you have a micromet in your lymph node, does it mean it is also in your bloodstream?
So it actually does not. And this is an area of significant interest and controversy, actually, within melanoma. So I didn't show all of the different plots for the risk of a recurrence, but melanoma has an unusual feature in our staging system such that patients who have stage 2C melanoma with a very deep primary, more than 4 centimeters, and ulceration, actually have a higher risk of melanoma coming back than patients who have stage 3A melanoma. And so those patients with a micrometastasis that you're referring to are stage 3A. And those patients actually have a lower risk of melanoma coming back than a patient who had a deep primary. And so that would suggest, as a biological correlate, that actually not the case, that if you have those few cells in the lymph node or one cell, that it actually will come back. So we have, in hospitals where there's an interdisciplinary melanoma conference, which is the case at my institution, we really go back and forth with the pathologist and the surgeon and our medical oncology about what is the significance of that. If we really only see 1 or 2 cells, are those truly melanoma cells? Are they truly malignant cells? What are they? And that gets to be hard. And I think that's where a decision-making process that sometimes includes the patient probably is important. I think from my perspective, we tend to maybe overdo it in those situations and not take the risk. But I think conversation with the patient is very reasonable. So if there's 1 cell in a lymph node, it's not totally clear, and if the patient feels strongly that they don't want a completion lymph node dissection, that could be a reasonable way to go forward.
I know in European countries and a little bit here, some patients following up with ultrasound of their lymph nodes instead of having them removed. What do you think of that?
So that is a reasonable way to go forward. So there's a sort of a difference in practice between the United States and Europe. So in Europe, they use far fewer PET scans. And so they commonly will do surgery and then follow the lymph node basin with ultrasound, and if something pops up, they then remove that. And that's actually in the MSLT1 trial what they did. The patients who were on the observation arm weren't just observed, they also got ultrasound. in the United States, we more commonly get PET scans, which have a higher sort of sensitivity, meaning we pick things up more often. So we tend to use less of ultrasounds. But I certainly, there's the situation where a patient has a bad-looking lesion, and I'm worried that maybe, 3 or 6 months or something is too long to wait for a PET scan. I sometimes will bring the patient back and do an ultrasound in like a month and a half or 2 months or something, just to make sure I'm not in a recurrence in that area. But we don't commonly use ultrasound in the United States, although it's not wrong. It's just a difference of practice.
Right. And also, well, there was a theory at one time, I don't know if this is true any longer, but that if the lymph node actually picked up the met, then it was doing its job from keeping it to getting to your bloodstream. That your lymph system acts as a keeper to keep foreign bodies out of the bloodstream. Okay. So people generally speaking don't believe that that's a harmful thing to do. In the data that I showed, if that were to be true and to be robustly true, like makes a big difference, we would expect then that the patients who did not have sentinel lymph node biopsy substantially did better than the patients who did have sentinel lymph node biopsy. And we don't see that at all. If anything, we see that the patients who had sentinel lymph node biopsy have a really slight better outcome than the patients who did not have the sentinel lymph node biopsy. So I think that the data we have argues that removing those lymph nodes does not make a substantial difference. But, this is not a question that's been really well studied because, the study you would have to do is just like move lymph nodes in some patients and see if they get cancer, and obviously nobody would want to do that. Right. And then, so is there some importance to keeping your lymph nodes instead of having the complete lymph node biopsy? I mean, many patients who have the nodes are negative, and then they have lymphedema, and they're unable to work, or, they can have some pretty permanent disability from that complete lymph node dissection.
I think those concerns are valid concerns in terms of the side effects or the outcomes after surgery. I again will say that there's no evidence that suggests that your outcome from melanoma would be better if you did not have the surgery. But certainly there are side effects from surgery. So the question becomes, where's that balance? Doing the surgery does help us to risk stratify, there's no question. So if we don't evaluate the lymph nodes, and you have, so say you had a 2 millimeter lesion, that could be anywhere from a stage 2, stage 3C lesion, depending on what the lymph nodes show. So that would really change how intensely we would monitor for melanoma in terms of would we scans and CT scans, or would we just say you're good to go and don't need to come back? So that makes that decision harder, but that's an individual patient decision. If a patient told me I'm not interested in having any surgery for melanoma, then I would say to them, well, so how would you like to go forward in terms of monitoring for recurrence? Because I would kind of have to sort of logically worry that you could be the highest risk group, which means I might do CT scans very frequently to make sure I'm not missing a recurrence. But that may be the case that you're not. So then you would get a lot of radiation that perhaps you didn't need. So there's pros and cons, and I can totally see each side of the equation. I think it just needs to take into consideration for the patient kind of what they think the highest risk is. I strongly think that sentinel lymph node biopsies are definitely still indicated, because that, knowing whether or not a patient is stage 3 makes a big difference in terms of how often we do CTs and PETs. The completion lymph node piece of it, I think, is a little bit open in the air. I think it's not clear that it improves overall survival. That being said, if you have a really kind of nasty primary and you found that on the sentinel lymph node there was a bad-looking lymph node in there, it would probably be the case that the melanoma would come back in the lymph node basin, which means you might as well get it out. But again, I think that's up to a conversation between patient and doctor about their choices and why they would justify doing different things.
Absolutely, and I think that's the whole point of us doing this webinar is that this is a very challenging area where it's just not as cut and dry as well, stage 4 isn't that easy either, but stage 3 is certainly leaves many questions, and certainly you need a judicious doctor and you know, you need to be a team and work on all these decisions together. So I really appreciate your time today, and I know that this will be very highly beneficial to our patients. So thank you very much.
Well, thank you so much for the opportunity.
All right. Take care.